Hi, my name is Nehal Desai, and I'm going to go over infectious diseases, medications, and how they are used in treating those disease states. Um, Specifically, the first topic here I'm going to talk about is the antibiotic classes and its mechanisms here. So, to see how each class works, and let's take a look. So, antibiotics is the first section here I listed on the slide. Um, And following that, you'll see all the different types of infectious disease states. I listed, these are some common type of diseases you might encounter on the exam, so just be familiar with them. I will kind of discuss some details in terms of some disease states here, but mostly just to show how the antibiotics work. Um, Again, this is just a preview, so at least you have an idea as to how the medication works, so that it can kind of give you an overall idea as to how they can be used in different disease states here. So, as you can see here, these are some of the antibiotics I've listed. Beta-lactams at top, glycopeptides, then lipopeptides, macrolides, fluoroquinolones, aminoglycosides, tetracyclines, sulfonamides, oxazolidinones, and then nitroimidazoles, and then rifamycins. Now, I'm just going to tell you this, that there are some important considerations when using some of these antibiotics. Um, as you can see, aminoglycosides and the glycopeptides, for example, you might see on the exam regarding like some renal adjustments in those types of antibiotics. And then I'm also going to state that sulfonamides, that one has like a two-step mechanism. Specifically, if you're using something like Bactrim, which is sulfamethoxazole and trimethoprim. So understanding the difference between those that lead to the that prevents that enzyme. So they look familiar, but on the test, it might be they might try to confuse you or trick you to think which enzyme it's actually going to inhibit. So understand that. Also want to mention something about rifamycins, that there's three types of drugs here that fall in that class. Um, and one of them is mainly used for one of the infectious diseases, which I already previously discussed before when we talked about tuberculosis. So, and as you probably already know about the right therapy. So, I'm not going to discuss too much about that. Macrolides, you probably already heard of this, like azithromycin or Z-Pak, erythromycin, um, and clarithromycins. Fluoroquinolones like ciprofloxacin and levofloxacin and moxifloxacin. Um, I do want to mention something about that there is a black box warning when it comes to the fluoroquinolones, that it might lead to some types of tendon ruptures. As a counseling point, if you when you're talking to a patient, you have to at least give them a little bit of warning too, so that they understand what they're about to encounter when they get these kinds of side effects. Aminoglycosides like gentamicin and amikacin and all of those, that's going to be an important consideration when looking at the renal function for the patient. Then you have tetracyclines as well. Just one important thing about here is like there might be some discoloration, especially specifically like teeth discoloration or something, you know, uh, something that stands out in terms of side effects with tetracyclines, to understand that. Um, and also medications like tetracycline, doxycycline. As you know, doxycycline being used um, typically first line for any type of Lyme disease. So if you see a question there regarding Lyme disease, that's going to be your first line for that. And then sulfonamides, which is like um, which actually prevents like the folate pathway for like the bacteria used for uh, protein synthesis and all. So we'll talk about the stepwise mechanism of that. That one's a little bit more comprehensive, but I'll just give you a short breakdown as to like the end result, so at least you could see how it actually works. Um, and then oxalazole with dinones, which is things like linezolid. Again, you're going to see that as well as a another antibiotic that could be used. I have not seen it being used as like first line therapy for any case, but it is there um, for when treating a patient who has a certain type of infection, um, similar to like MRSA and those kinds of things. So just understand that. Nitramidazoles, things like metronidazole. Um, I do want to point out that when you see this class of medication like metronidazole or nitramidazole, I could tell you that the nitro part is the part that will kind of help you understand the mechanism here, because it's going to make the nitrate reduced or nitro reduced inside the bacteria. You'll see that in the mechanism. And then rifamycin, which you saw, rifampin. Um, uh, One other thing I want to talk about is the um, uh, some of the quick mechanism guides or tips here that will help you in understanding the drugs. Specifically when it comes to aminoglycosides. Amino meaning like amino acids, it's going to go when the mRNA is being read through the 30S ribosome. You'll see a picture of how aminoglycoside interact in there, and then it reversely binds to it, and it prevents the aminoglycosides from properly being read, or it will insert the wrong aminoglycosides in the group, so it will kind of disrupt the overall protein synthesis. So you can kind of make that out there. Tetracyclines, tetra, um, kind of like 30S ribosomes, where it's going to bind and prevent that formation. Then you have macrolides, macro mean big, so 50S here. So kind of like looking at that way. So let's take a look. And I do want to point out one other important point here, specifically when it comes to metronidazole, nitramidazole, knowing that alcohol should never be taken when taking metronidazole. So it's an important patient counseling point to avoid alcohol use when taking metronidazole. And that's mainly because it can lead to flushing and all of that severe side effects as well. So um, it's important to note that as well. So beta lactams is typically they bind to a penicillin binding protein within the bacteria cell, so it can prevent the cross-linking of the peptidoglycan and then make the cell wall weak and unstable. So it's going to cause the cell lysis, which is bacterial cell death. So one way to think about this is because what happens here is bacteria need strong peptidoglycan cell wall to survive the osmotic pressure. And whenever the cell wall becomes weak, it's going to make the cell wall very unstable and weak when the beta lactam binds, and then it's not going to be able to withstand the osmotic pressure. So it's just going to burst through the bacteria and basically destroy the cell. bacterial cells. So that's essentially what this does. Now, some beta lactams are going to be broken down by some beta lactamase that's produced by the bacteria. So you might see bacteria, you might see antibiotics like amoxicillin, but sometimes amoxicillin is incapable of, breaking down the cell walls because it's going to get eaten by the uh, beta lactamase. And some bacteria produce that, so that's why they use amoxicillin clavulanic. So that clavulanic will inhibit that lysis of the or the breakdown of the amoxicillin, so it can actually be a little bit stronger um, uh, in terms of cell death and in terms of killing the bacterial cell. So that's one way to think about it. So you beta lactams or beta lactam uh, lactamase inhibitors, sometimes you guys see a choice, you might see a multiple choice to see which one would be better. Is it going to be amoxicillin or amoxicillin clavulate, or in other words, a brand name augmentin? Um, you always want to go with whatever's stronger, which is augmentin. Unless the patient's allergy to clavulate, then you would just have to use the amoxicillin. Now, if they have penicillin allergy, you just can't use beta-lactam. You have to use something else. Um, so just giving you a little bit of tips here. Glycopeptides, these are going to actually bind to the peptidoglycan that end in D-allo, and so it's going to bind to the substrate, not the enzyme, like the penicillin binding protein enzymes. Um, and it's going to block the cell wall assembly, so prevents transglycosylation and transpeptidation. So it's going to prevent both functions here. And so the cell wall cannot form properly, it's going to weaken and cause cell death. So like one example, like vancomycin. Vancomycin is going to generally do this type of thing, but one thing to be careful is really when taking vancomycin is really the renal function. So making sure that patients renally um, adjusted before administering vancomycin, specifically to treat MRSA type infections. So just kind of giving you a tip here. So that's pretty much that for this type of pathway. Give me 1 second. So yeah, so and other bacteria like Listeria, Streptococcus, all those kinds of things it's gonna help with. Um, but vancomycin, you might need to check the renal function before treating the patient, specifically giving them an IV of vancomycin. So that's an important note here. The nitramidiosols, I drew kind of like this orange axis here to represent how the free radical formation within the bacterial cell, so that whenever you know a metronidazole taken, it needs to work in an anaerobic environment or no oxygen environment, because that's how it's going to passively diffuse in there, and then it's going to cause nitro group to be reduced. So um, this requires low oxygen environment, so it can form free radicals reactive free radical metabolites and then damage the DNA and cause the DNA strands to break, leading to cell death. So I thought this was interesting, how it can kind of just insert those um, kind of like poison inside the bacteria. So it's kind of like taking, I guess you can think of metronidazole like going through metro or within like a tunnel, and then kind of uh, just getting into another place, and then just um, like you're talking about a train, you're in a metro train, and then you have a bunch of passengers or a bunch of these less passengers as like drugs that's going through a tunnel and then coming out into the like another world or inside the bacteria, and then those passengers come out and kind of like spread over the place and then destroy the DNA. So you can kind of think of it like that. Um, in the class name nitro, like the nitro being reduced inside the um, cell. So that's another way of thinking about it. Again, this is also this DNA damage is irreversible and causes bactericidal. So it's going to it's going to kill the cell overall. Lipopeptides like daptomycin is an interesting drug here. It is going to require calcium, so it's from the extracellular service. I really like this. I really like this illustration because it kind of represents how calcium is needed to bind to daptomycin in order for that lipid tail to um, insert itself into the membrane. So you can see like step one, here's calcium, step two, calcium and daptomycin are together, not linked, but they are kind of close together here. And then you can see three, they link together and then they go, and then it the calcium is essentially used to activate the daptomycin. Daptomycin is kind of like a prodrug, but because it needs calcium to be activated, and then it will insert itself inside the lipid, inside the cell membrane, and then it's going to lead to rapid membrane depolarization, cause the potassium to go out of the cell, and then lead to cell death. So it's going to inhibit the DNA synthesis, RNA synthesis, and protein synthesis. So it's going to be bactericidal or rapid kill, which I think is it's pretty cool mechanism um, for a bacteria um, to get killed. So these are some interesting illustrations here. So just kind of understand that dactomycin has to be activated with the calcium. So if they have a multiple choice question asking you which of the following electrolytes or which of the following molecules is needed with dactomycin to activate this cell membrane, it's going to be calcium. And so note that as well. Macrolides. So now we start looking more into the ribosome or the internal parts of the bacteria. So macrolides are in the terms in the name is macro, mean big. So you're going to look at the bigger portion of this ribosome, which is 50S and 30S. That's how this ribosome is divided in. So the macrolide is going to work in the 50S and prevent that elongation of the peptides. So you can see here, it's going to target the 50S ribosomal subunit. It's going to prevent the movement of the ribosome along the mRNA, prevent the growing of the peptide chain from moving forward. So that's what it's going to help with. And then protein synthesis stops. So bacteria can't grow or replicate, so it's going to be bacteriostatic. Now, because it's not going to grow or replicate, that's why it's bacteriostatic. You can kind of see that in this picture. You can see how the peptide chain is growing. That doesn't mean the bacteria will just completely stop or die. It can still um, kind of still produce proteins, but it's not going to produce, it's not going to, it's going to stop it from moving forward. So, just kind of differentiate between bactericidal and bacteriostatic here. Macrolides are going to typically be bacteriostatic. Fluoroquinolones, fluoroquinolone like topoisomerase 4 is used typically for that DNA replication. So you can see here, fluoroquinolones are going to bind to that topoisomerase 4 enzyme, so it doesn't do its work with the DNA, and it will block the DNA uncoiling and separation, and then freeze the DNA in its broken state. So essentially, that's what it's going to do. And then DNA replication transcription will stop, and then cannot be copied or repaired, cannot divide or survive, and it'll be bactericidal. I kind of drew a little bit of a blue square circle type of thing just around the DNA, kind of like showing that it's going to freeze it from freeze in separation or in broken state. So it's not going to, if it does break apart, it's not going to be able to do anything more. It's going to prevent that replication and transcription. So essentially, that's what it does. I do want to note that sometime on an exam, you might get a question or two about topoisomerase 4 versus topoisomerase 2. Topoisomerase 2 is typically mainly in the gram-negative, and topoisomerase 4 enzyme is mainly in the gram-positive. So know that fluoroquinolones are used to prevent both. But in this case, I just listed as topoisomerase 4. So note that as well. That is very important. I'm not going into very detailed on this. There's a little more complicated structure here, but at least knowing that it's going to at least prevent the replication transcription. So that's important point here in terms of how fluoroquinolones will work. In fact, it's not going to actually freeze DNA from separation. It's just going to freeze DNA in its broken state. So it will still break, but it's not going to work as it should inside the bacterial cell. So that's essentially it here, and it is bactericidal as well. It's going to directly kill the bacteria. If you have any other questions, feel free to comment or let me know. We can look more into it. But otherwise, you can just check your resources and see if you would like to learn more about how this works. It should tell you in there as well. Aminoglycosides, hence the term amino. And again, you can see how I kind of grouped the diagrams together now. This diagram is just very similar to the other ones. So aminoglycosides is another one, but look at the name here, amino. Amino as in amino acids, amino acid being made to make proteins. So you could see here kind of in the name already here, and you could see in the diagram how I kind of pointed a green arrow here or green drug structure, so it kind of binds to the 30S and insert the wrong amino acids in the mRNA group. So it's going to be read the wrong way, and then it will destroy the bacterial wall. Tetracyclines, like it's going to do the 30S. So it's going to bind. This one is actually going to prevent the binding of the tRNA, amino acyl tRNA, to the A site. So that's essentially what happens here. And it's a reversible binding to 30S. And it's going to block the tRNA attachment, and no amino acids are added to the growing peptide, protein synthesis stops, and bacteria cannot grow or replicate, so it's going to be bacteriostatic. Sulfonamides. This is the part where I was explaining that it might be a little bit more complicated structure, but it's kind of simple if you look at it. You don't need to understand all this other small detail here. The first thing I'm going to tell you here is, first of all, between humans and bacteria. In a human, we actually get our folic acid or folate through diet. In bacteria, they actually produce their own folate. So that's the difference here. And then when that folate is made, it's going to make something structurally similar, which is PABA. And PABA is used in the process, basically, in terms of making that folate. So you can see here sugar being converted. It gets converted all the way until it forms PABA, and then what happens here is PABA converts to dihydropatoric acid, and then dihydropatoric acid converts to DHF, which is dihydrofolate, and then the THF. And then what happens here between this and two mechanisms here is that sulfamethoxazole is used to prevent the dihydropatoric synthase, and trimethoprim is to prevent the conversion between DHF and THF. So that's the difference here, which is going to be, and I'll read it to you here, that they're going to target, their target is the folic acid synthesis. So bacteria must make their own folic acid. Humans get folate from diet, so it's selective toxicity. Sulfonamides mimic the PABA. So you can see here that sulfonamides mimic it. So, and then inhibit the dihydropatoric acid synthase. And so that's the early step. Then, the later step, which is DHF to THF, prevents that. So with the end result being that there's going to be a decrease in folic acid. So folic acid is an essential ingredient used in DNA synthesis in the bacteria. So without the folic acid, DNA synthesis won't occur very properly. It's going to be impaired. And because what happens is no folate is going to lead to no thymidine. So thymidine, an important part of the part of the DNA, is not going to be used. So synthesis of DNA is not going to occur. So it is going to be bacteriostatic alone, but if we take in with a trimethoprim, so if it's sulfamethoxazole and trimethoprim together combined, it's going to be bactericidal. So note that you can't just have one without the other to make it bactericidal. So you need both. And I also wanted to point out one important side effect with a trimethoprim is it can lead to increase in like the potassium levels. If I recall, trimethoprim there is a mechanism in there that will cause it. You can look into my previous shorts on that. but it's another thing to watch out for in terms of uh, the trimethoprim. It's going to block the ENaC, or the epithelial sodium channels in the distal tube or collecting duct of the kidneys. So it's going to decrease the sodium reabsorption, and the potassium is going to be retained. So that's essentially what that will do. So if the patient is on another medication, um, like a let's say they're on lisinopril, or let's say they're on potassium, for example, yeah, you want to actually monitor the potassium levels, um, and check to see how their potassium levels are when taking sulfonamide with a potassium sparing drug, or um, you know, potassium type of drug. Um, so a lot of times in the hospitals, or when you're in practice, you might see patients that have high blood pressure, and that they're taking high blood pressure medicines that will increase their potassium levels. But then they might also be on this type of medication, which is the Bactrim. It could be Bactrim DS or Bactrim SS, doesn't matter. But if they are on a Bactrim and they're on these kinds of potassium sparing type of drugs, or potassium sparing diuretic, or a lisinopril or losartan, definitely make sure that the potassium levels are monitored uh, before administering a sulfonamide, or when talking to a patient about it, because um, elevated potassium can also result in side effects as well. So I don't want to go off topic here, but I do want to let you know that if they ask you a question of which of the lab monitoring levels or labs need to be monitored, um, you need to know that potassium is going to be the main concern here with this antibiotic. And then the next one here is a linezolide, or linezolide, or however you would like to call it. Um, it's a oxazolidinones class of medicine, and what it does there is going to bind to the 23S rRNA and of the 50S ribosomal subunit. So this one, I have a tip here for you so that you can remember it for the exam. Linezolide, think of the name line, like line up. So these things there's three parts that's gonna line up. You have the 50S, you have the R30S, you got the mRNA, and you have the initiated tRNA. And so all four of these make up the initiation complex formation of this whole group of ribosomes and this tRNA and mRNA. So if this linezolid is taken, it's going to prevent the um, 50S plus the 30S plus the mRNA plus the initiator tRNA from binding and or from assembling. So it's going to prevent the lineup of these four parts of the initiator complex. So lineup, or linezolide, it's kind of like a easier way for you to remember the oxazolidinones mechanism. So I hope that helps. Protein synthesis never never starts. And so there's no initiation, no elongation, and no proteins. So it's going to be bacteriostatic essentially. So we talked about how macrolides can also lead to preventing of the elongation. This is another medication that prevents the elongation as well. So, um, so note that this is another bacteriostatic type of drug in the 50s. But the difference here is macrolides it's just gonna work straight to the uh, prevent that elongation, whereas this is going to prevent the um, whole initial complex from forming together. So this one's going to prevent that lineup. The other one's going to prevent that macro part. Or I'm sorry. Well, you can think of a macro part like building up of the protein structure all the way to the top, or preventing the elongation. But yeah, so hopefully that kind of helps with understanding some of these mechanisms. Um, Rifamycins. We talked about RIPES therapy, rifampin, isoniazid, pyrazinamide, and the um, uh, what was the last one? Let me give that to you real quick, so at least you see it. It's the ethambutol. So I'm going to tell you quickly, actually, right here, what distinguishes each one. So isoniazid is the one that's going to lead to more of a peripheral neuropathy. So it's better to make sure vitamin B6 is taken. Because that will actually lead to that kind of side effect with the lack of vitamin B6. The rifampin may lead to orange discoloration, and the pyrazinamide, hyperuricemia, ethambutol with the optic neuritis. Ethambutol, we already talked about previously about how it might affect vision. So think of like ethanol, alcohol, kind of leading to vision problems. Pyrazinamide, um, hyperuricemia, hepatotoxicity, so something with the liver might affect that. Rifampin also with the liver, but to distinguish it from the pyrazinamide is the orange discoloration. Um, it might be like the orange discoloration of the, 1 second. Sorry, my system is just not working properly, so give me a second. Okay, so it might lead to discoloration of the urine, sweat, tears, saliva. So any of those things um, with rifampin. And I want to also mention isoniazid, which also could lead to hepatotoxicity, peripheral neuropathy. So that's where vitamin B6 is important. If you were giving a question on the exam about which vitamin to administer while you're taking the isoniazid, then you have to state vitamin B6. Okay. So anyways, going back to the mechanism here on rifamycins. Rifampin stops the enzyme from functioning and transcription stops. It's going to bind to this DNA-dependent RNA polymerase so that it doesn't convert or prevent the transcription, which is responsible from converting DNA to RNA. And without that RNA, what happens? It's going to stop. It's going to prevent the mRNA from being produced, and then it's going to lead to no protein synthesis and cell death. So without mRNA, ribosomes can't make proteins. So that's essentially what's happening here, and you can see it right here in this diagram here. It's binding to the beta subunit of the RNA polymerase. So that's what's happening here. I kind of drew a little receptor diagram and how the rifampin is binding to that RNA polymerase and then blocking that transcription phase from the DNA to RNA. so it can't make that mRNA. And then for transcription, for translation process, and lead to no protein synthesis. So hopefully it kind of gives you a little bit of idea how rifamycins work. Um, at least now you kind of have an understanding as to the derived therapy too. I had to go back and a little bit recall some stuff here, but um, for exam purposes, I kind of list out some tips here so that you know exactly what the different um, type of medications used in this disease state, specifically for tuberculosis.